Thank you very much, Mahak, for accepting our invitation and coming on board for Urban Talk and talking about urban sanitation and COVID-19 in the context of India. During last year, we often hear actually very much reassuring statements about urban sanitation. We hear that, for example, buses are disinfected on a daily basis in some cities and that sort of things. But we understand that for many communities, for many parts of the cities and communities, these kind of statements are kind of a luxury statements. And we know that COVID-19 doesn't affect different communities equally. So it will be very interesting to see the story from India, and not only from India, but also from the urban sanitation perspective, because you were a medical student turned into urban planner. And what are your reflections, and what do you think can be the way forward in this regard? Thank you.
Thank you very much, Farnaz, for having me here. And as you rightly said, that sanitation and sanitation deprivation is a big issue in India and other parts of the world. And today I would be highlighting what urban sanitation deprivation really means in the context of urban India and how it played out during the COVID-19 crisis and what could be the possible ways ahead. So I will start a screen share right now. Okay, I hope the presentation is visible.
Yes, it is.
Okay, thank you very much. Okay, so good morning, good evening, and good afternoon to anybody who's watching the presentation today or later on. I, Mahak Agrawal, will be taking you on a sanitary virtual trip to India, more precisely the urban India. But before I delve into India, let us look at a number, which is 96234. This number, a significant number actually, indicates the average number of people who gained access to improved sanitation since yesterday. And this number comes from the UN. But there are evidences of open defecation and sanitation deprivation that are emerging every day from all over the world, be it Haiti, be it China, be it Vietnam, be it Russia or any other part of the world. We find evidences of sanitation deprivation, of open defecation and inadequate sanitation from all around the world. And yes, from India as well. Translating these numbers and narratives of access and deprivation across geographies, we can see that there is a global call for sanitary change, a call that is not confined to low or middle income countries. So that's one of the major global sanitary misconceptions that goes out of the window. However, these global sanitation data, it often hides more than it tells. For instance, it does not reflect the population that gained access to any form of sanitation, yet continues to defecate in the open. These numbers, they don't reflect the population that has access to sanitation, but its functional use is limited, making people use the facilities once a day and defecate in the open twice or even more than twice a day. These numbers also do not reflect that access to some, but only a few, often meals in public spaces, is over-prioritized over the access for everyone. But these numbers are crucial. They guide planning, they guide public policy, management, funding, and whatnot at all levels of space, time, and governance. When it comes to urban India, this data hides narratives of deprivation. In terms of India, there's a long urban sanitary history which needs to be dug deep to eradicate open defecation. The country has centuries-old societal laws with the sanitation dimension manifesting itself in the caste discrimination, promotion of community toilets, and toilets outside premises. During the British India regime, sanitation deprivation and environmental degradation led to emergence of urban planning that was driven by principles of spatial, social segregation and inequities of access. Post-independence, urban sanitation continued to be a small part of a larger scheme on housing, on water supply, poverty reduction, and in 2008, the first ever independent urban sanitation policy was notified by the central government. But the policy focused on a fixed frame of benchmarks for the entire India. In 2014, Prime Minister Narendra Modi launched a pan-India mission called as Clean India Mission, which is also known as Swachh Bharat Abhiyan. The mission was launched with a vision to eradicate open defecation by October 2, 2019. This was a landmark event because sanitation became a national priority overnight and had a dedicated plan of action for eradicating open defecation. 6 years down the line, the country has been hailed as open defecation free, but a lot of the parts of the country and the capital of Delhi continue to drown in its own waste. For planners, for geographers, when it comes to urban sanitation, we focus on numbers and on land. How much population are we expecting in 20 years? Let's calculate the water demand, the waste generation, and augment treatment capacity. But this method of land budgeting has not worked in the past or the present and is guaranteed to not work in the future. This can also be explained with set of two maps. In the first one, we can see that almost entire city of Delhi has access to water supply, but only 60% of it is connected to sewerage network as visible on the right-hand map. As a result, treatment facilities are not functioning at full capacity and nearly 48% of the city's population is defecating in the open. In the second set of maps, we see that in the past two census counts, access to toilet facilities has increased significantly, yet open defecation instances have not reduced. Well, we'll have to see what the numbers tell in the next census because of the Clean India mission, which is due to come out anytime this year or the next year. But overall, it indicates that mere provision is not enough to end open defecation. Few of the narratives that I have collected in the past few years of my work on sanitation deprivation across Delhi highlight issues of defunct facilities, challenges of having facilities in numbers but absence of use, challenges of limited accessibility forcing users, particularly women, girls, elderly, and differently abled, to use facilities by day and defecate in the open by night. There are also instances where most common challenge that the population is facing is to travel in packs to these distantly located facilities because of the fear of sexual or even physical harassment. Yet, people are adapting. People are adapting to whatever facilities are provided to them for a bit of dignity. And the situation has worsened during the COVID-19 crisis. With COVID-19, the notion of 1.5 meter city gained importance. Value of public health, hygiene, and improved sanitation became critical. But in these corona sanitation debates, informal habitations or slums, where social distancing is a privilege, were put under the spotlight without actually improving the access to adequate, let alone improved sanitation. In the end, for Delhi or any other Indian city that is expanding in number in its physical size as well as population size, areas of deprivation and the extent of deprivation is expanding as well. For truly eradicating open defecation and providing access to public health, we need to first and foremost identify the potholes of the system, which include misplaced focus, centralized systems, mindless provision, inaccurate data, and limited scope of planning and management. Next, we need to rework our current systems and work with the bits that work and rework the bits or missing links which will work. In doing this, we can use narratives to build facilities people will use health risk zonation to assist urban governance, emergency preparedness, and response and reimagine urbanism. We also need to fix and fill the data gap on which SMS services in multiple languages will go a long way. Essentially, using crowdsourcing data to identify deprived areas and most disadvantaged cohorts across cities and regions can help fix a lot of the data issues. Other ways forward rely on reworking the census frame of sanitation data collection. We need to rework the method of wastewater calculation based on access to sewerage network. We cannot simply rely that X is the number of water that is provided to the population and 80% of that is sewage. That's not true. We also need to update the method of assessment and monitoring to include dimensions of functionality, accessibility, sustainability, efficiency, and affordability. And we need to play out these parameters at not just city level, but at community and at household level as well. Lastly, we need to mandate audit checks to check services for their usability, not just mere provision. In 2019, with the support of Change.org Foundation, I initiated a petition to hold the government of Delhi accountable for the human right to sanitation. In 8 months, we gathered over 200,000 in global support for the demand of basic human right to sanitation. It led us to discuss the actions with the Chief Minister of Delhi, but unfortunately, as we were about to implement the actions, COVID struck, and instead of actually being prioritized as one of the most significant issues in fighting against a disease where public health is important, access and use of facilities in the slum clusters was not prioritized to the extent that other issues were. And lastly, also, we need to look at 360-degree perspectives of open defecation and sanitation deprivation to think about the issue as something that extends beyond a cultural outlook of the urban poor or the rural poor in India. And with that, I'd like to thank you for being kind and being patient. Thank you.
Thank you very much, Mahak, for a very insightful and in-depth presentation you provided. I really liked your argument that numbers are not enough. Accessibility, affordability, they are it, and other factors are very important.
Yes.
I have a question, especially with regards to the health risk zonation, the concept, which is very interesting. Is it just about diseases, or transmittable diseases, or you are thinking about the broader, actually, health-related urban risks, for example, urban pollution, air pollution,
Yes, so essentially, so far, health risk zonation has not been popularized in India. And whatever health risk zonation that has existed till now, it has focused on one or maybe a category of health risks. So for instance, vector-borne diseases such as dengue and malaria have been quite common in the urban India for a very long time. And if we look at health risk zonation, they would usually be highlighting that across a city, which are the pockets that are most at risk to, say, dengue or malaria. So far that has been the way the government has approached health risk zonation, that is to pick up a disease and work towards that and identify in the process that which are the hotspots. But what I intend to say is that when you're talking about health risk zonation, we need to bring in majority of the risks that are high level risk, which include the issue of open defecation, because it's an issue that is often equated as a social justice issue, and it is not really included into the public health crisis, especially when you're talking about health risk zonation. And that is something that we need to bring in, because sanitation deprivation has an impact on not just the urban poor, but the surrounding community and the city at large. And it is really contributing to waterborne diseases as well as vector-borne diseases. So we cannot afford to actually keep on ignoring it from the risk zonation.
One can argue that this issue of urban sanitation, this is an extreme case in India. Anyone who has visited India, at least probably before 5 years ago, 6 years ago, before 2014, the image, you know, we carry that also from India. So to what extent you think that this is also applicable to other developing countries? You mentioned China, Vietnam, and other countries.
I think it's very applicable because of the way we have traditionally approached urban sanitation and open defecation as a matter that is affecting the poor. But in fact, like when I started working in the domain, I thought that it is something that is a cultural value, or it's something that is like preferred over using facilities for the urban poor, because a lot of the times urban poor are the people who are migrating from rural areas, and in rural areas, there is ample space. There are societal norms that govern that the facility should be away from your household, which incentivizes, or rather which does not disincentivize a person to not defecate in the open. And that sort of thinking has come to the urban area as well. That is what even I thought, because that is what is there in the literature. But when you go and really talk to people, whether it's in India, whether it's in China, or whether it's in Africa or Indonesia, where I have actually spoken to people, it's in urban setting, it's really difficult to defecate in the open as something as a preferred way, because in urban setting, no matter where you are going, you are in the eyes of the public, and that is a matter of dignity, and that is a matter of shame. So we cannot move forward with open defecation or sanitation as something that is common, that has common manifestations in urban or rural counterparts. And we cannot say that in urban setting, it's a matter of culture, because it's not. It's a matter of providing facilities that are not usable. It is about providing facilities that are not adequate in numbers, because in some parts of India, for instance, in Mumbai, you'll find that one facility that is not even adequate, it's being used by over 600 people in a day, which is absurd. Similarly, in Indonesia, you'll find population that is living along waterways in very uninhabitable areas, but then again, like facilities are situated in a way that they are overburdened, they are inadequate. But again, people or the administration would not be prioritizing it, either because of the value that they associate with the defecation issue, or because of the charitable nature with which we provide facilities to the urban poor, who is often considered as an illegal tenant in the city. So I think that, yeah, it's a very complicated issue, but it has, the case of India has an impact on, has an applicability to other parts of the world as well.
Thank you very much. That was great. I hope there were many areas actually in your talk that they deserve to have another talk, you know, focusing on them specifically. So I really hope that in the future we can have you another time for those talks as well. Thank you very much, Mahak.
Thank you very much, Farnaz. It has been my pleasure, and I look forward to the next times.
Thank you.